Hi, my name is Alicia Yeaman, and this is the second part of a two-part series of videos on gender stereotypes, and reproductive health and rights. So in the last video, we talked about gender stereotypes and how to identify them and dismantle them, in particular in judicial opinions, but elsewhere as well. Today we're going to talk about going beyond judicial opinions or good law and looking at how sexual and reproductive rights, especially of adolescents, are respected and promoted within societies and health systems. Last time we talked a lot about gender and gender discrimination, but we also noted that gender is wrapped up in other threads of identity, including race, sexual orientation, income, and wealth status. So today I'm going to talk first about inequality and adolescent fertility. In countries where there is greater income inequality, whether high income or low income or middle income, we also see higher adolescent birth rates. We also see a connection between poverty and adolescent fertility. So there are two ways to think about this. Either because young women and their partners are living in poverty, they may have dropped out of school and decide to couple early and have children earlier. The other hypothesis is that when girls drop out of school and get pregnant and have children, they are then foreclosed many other opportunities in their life plans. Adolescent sexual and reproductive health is an issue in the Sustainable Development Goals. In the health goal, Target 3.7 talks about the proportion of women of reproductive age, and that begins at 15 to 49 years who have their needs for family planning and contraception satisfied. And in the gender equality goal, Goal 5, Indicator 5.6.1 talks about the proportion of women, again aged 15 to 49 years, who make their own informed decisions regarding sexual relations, contraceptive use, and reproductive health care. And Indicator 5.6.2 talks about the number of countries with laws and regulations that guarantee women aged 15 to 49 access to sexual and reproductive health care information and education. So we've seen that despite the Sustainable Development Goals, in national contexts, there are pushes to control adolescent sexual and reproductive health in particular. The idea that young women, that girls need to be, their desires, their bodies need to be regulated and controlled, whether in antinatalist ways or pronatalist ways that deny them access to contraception, sexuality education, and abortion. So what do health systems have to do with this? They're core institutions that reflect and refract back to us the values that are embedded in society, whether that is discrimination against women or stereotypes in gender or exclusion on the basis of lack of income or marginalization because of disability or because of age. Adolescents and young women are often among the most excluded or mistreated by health systems who require different forms and barriers of consent for them to get services. So on the one hand, we see in some countries there is antinatalist policy that imposes forced contraception on young women and older women. And in some countries, there is a policy of ignoring or disregarding the will of women who find themselves abused or disadvantaged or marginalized. One way to think about how to analyze health systems and whether they're respecting sexual and reproductive health and rights is by looking at circles of constructive accountability, as Lynn Friedman says, throughout the policy cycle. So first we need to look at the legal and policy frameworks. And to ensure that those legal and policy frameworks enshrine women and young women, girls' rights to sexual and reproductive health, that they don't impose any unnecessary or discriminatory barriers. Often access to certain services such as abortion require adolescents to get parental consent or judicial consent. And there can be consent requirements, but they have to be reasonably enshrined in law and implemented in ways that don't pose undue bureaucratic obstacles. Second, there need to be national plans and strategies in place. So in the case of adolescent sexual and reproductive health in particular, those national plans and strategies need to be multi-sectoral. You want to teach sexuality education in schools, not in clinics, but in schools. So that needs to be in the education sector. Third, there should be a budget that reflects the commitments that have been made in the national plans of action and in the law. And sometimes that budget needs to be decentralized in decentralized health systems. Then we have program implementation. Even when there are good laws and good plans of action and strategies, even when they have been budgeted for, often it's when programs are implemented on the ground that women and girls are denied access to certain services or goods that they require or don't receive the treatment that they should receive under law. Fixing program implementation requires ground-up actionable information from communities. There's also a need for monitoring and evaluation. Monitoring and evaluation that, one, disaggregates the information so that it in fact is actionable. So disaggregates by income quintiles, by ages, so that you can see what are the age groups that are most in need of having abortion services, for example, based on this kinds of information from the Guttmacher Institute. Disaggregated in terms of public and private facilities and looking, for example, at where are women most likely to have cesarean sections, even far above the recommended range for cesarean sections from the WHO or from the best evidence in public health. So the monitoring and evaluation needs to disaggregate both by population, but also by public-private, and to try to discern and give actionable information for social change. Remedies should also be directed at social change. Remedies can too often be thought about only in terms of punitive accountability, so punishing frontline health workers. And sometimes that is appropriate when there's willful mistreatment of women and girls, or willful denial, knowing denial of care or services against the law. But often we don't want to use punitive sanctions, and particularly criminal sanctions, because it's not the frontline health worker, it's more of an institutional change issue. We don't want women prosecuted criminally for seeking abortions, for example. We don't want doctors who perform abortions under the conditions allowed by law to be prosecuted. And similarly, we want to use remedies in general to create incentives to change the system. So create incentives and change incentives so that doctors are not put on quotas, for example, for bilateral tubal ligations, so that doctors may claim conscientious objection in certain cases, but need to do so in writing pursuant to certain procedures. And institutions cannot claim conscientious objection with respect to abortion, for example. Similarly, with obstetric violence, it's not just a matter of prosecuting an individual provider who performs an episiotomy or a cesarean section that's not necessary. It is a whole circle of creating different incentives and looking at how providers are trained, the institutional culture about treating women as people with agency and not as bodies divorced from their social space. International actors also have obligations. First, for extraterritorial obligations, at a minimum, they should not be doing harm. As in, for example, I would say the global gag rule. Similarly, there should be some kind of accountability in the way money is spent. And that is difficult in global development and global health now because so much of global health is based on complicated relationships and how those investments are used. So it's very difficult to hold global health institutions or governance structures to any kind of meaningful accountability for sexual and reproductive health and rights. So the goal throughout the circle of accountability within the health system and more broadly is to allow women and girls, young women especially, to feel welcome in the health system, to have their dignity respected, to have that health system reflect back that they are equal and full members of society whose dignity matters, whose lives and choices matter. We often don't realize how fundamental a role the health system plays in excluding or exacerbating exclusion of certain populations because they're from a minority, because they're impoverished, because they have a disability, or because women and young women are seeking certain kinds of stigmatized services. It's so easy for the health system to end up re-traumatizing, especially these young women who may have been the victim of abuse, physical or domestic abuse, or sexual assault, instead of enabling them to feel that their suffering matters, respecting the sexual and reproductive health and rights of women and young women in particular means addressing those structural injustices that undergird gender inequality, but it also fundamentally means trusting women, including young women, and providing them with the conditions that enable them to make responsible or appropriate decisions for them in their lives. Young women and all women need protection, but they also need freedom and agency and the ability, just as men do and take for granted, the ability to live out lives that they plan, their own lives of dignity within their social networks, within their societies. That is really what these struggles for sexual and reproductive health and rights are about. It's not just that some women get access to some kinds of packages of care. It is about being treated as fully a member of your society and of this globalized world.